I thought that we would talk a little bit about adolescence, some important points in adolescence that I feel may not be completely picked up in the articles and the readings that you have, although Burns does really a fine job with talking about adolescence and the relationship of the healthcare provider to the adolescent. But I wanted to do some review of growth and development in this period just as a reminder to you about what's going on here, so that you perhaps then will have a little better ability to monitor the adolescence that you see in practice. So if we look at the development during the adolescent period, there's a dramatic physical growth, the most rapid since infancy, that occurs during this period. And recently discovered as part of that physical growth, not only growth in linear height and weight and sexual maturation, as we'll talk about, but also some rather dramatic growth in the central nervous system. Used to be thought that you didn't develop any new neurons after you were about a couple months of age, but there actually has been some research that shows that during puberty, adolescents may actually develop some new neurons. So there's some pretty dramatic central nervous system changes going on too. Development in other areas, there's the development of abstract thought, what's called formal operational thinking. We'll talk a little bit about adolescent egocentrism and what that means, and then about identity development as described by Erikson and others. So let's talk about growth and maturation first. We did some of this when we talked about the endocrine system, but I just want to review it so that what we see is the pituitary hormones becoming very active during this period, and growth hormone producing some dramatic physical growth, and then the pituitary gonadotropins really starting up, so that we see the beginning of production of large amounts of estrogens and androgens, which produce both primary sexual change and secondary sexual change. The primary sexual changes are the ones that make you capable of reproduction, and this is growth of the ovaries and production of ova, and in girls the onset of menses. And in boys, this is the growth of the testicles and penis, and then ultimately sperm production. Those we can't see very easily, but the things that we can see are the secondary sexual changes, so that our decisions about how this is proceeding are kind of based on the secondary sexual changes that occur: breast development, pubic axillary hair, change in body proportions. In girls, increased percentage of body fat and increased secretion of sebaceous glands, and some of the same things in boys, but there we see increased muscle mass and a deepening of the voice and the development of more of facial hair. And this leads us to the Tanner ratings, so that this is usually how we're deciding whether puberty is proceeding normally, is by looking at the sexual maturity rating of Tanner. By now you're probably familiar with this, but Burns has very good diagrams of each of the sexual maturity rating stages, so 1, 2, 3, 4, and 5, and this is a description of them, but I don't really have pictures in here, so go to Burns and have a look at those pictures so that you can appreciate what it looks like, so you're able to provide an SMR rating for the patients that you see. So for girls, usually the first thing that we see is a little bit of development of a breast bud, and that usually in most girls precedes pubic hair, but not always, and then the various stages of that development that you see there. Of course, an important thing here that tells us about sexual maturity too is menses, which is really not in the Tanner rating, but we'll look at that relationship in just a minute. And for boys, what you see first usually is development of some pubic hair, and then the changes that you can see in the penis, and you can see enlargement of the testicles occurring too. So this slide really tells you about the changes in the levels of testosterone and estradiol, and it's helpful because you see in boys the dramatic increase in testosterone and in girls the estrogen. But note that there's also some changes in the other hormones for each of the sexes. So boys do have some increases in estradiol, and girls have some increases in testosterone. The increase in testosterone in girls accounts for some of the hair growth and also some of the acne that you see in girls. And the increase in estradiol in boys also accounts for sometimes the gynecomastia that you see early in puberty in boys, where they look like they're getting a little bit of breast development. That usually stops pretty quickly and is masked by the growth of the rest of their body, but sometimes can be pretty distressing to boys. And as far as physical growth here, we see a good diagram that shows you that there's about 1 to 2 years difference in physical growth in females and males. And all you have to do is look at a middle school class to know that this is true, or remember your own experience at that age where the girls here are taller than the boys, and for a period of time. This is also has a parallel in bone maturity in females and males as well, so that you have closure of the epiphyses earlier by 1 to 2 years in girls as opposed to boys, and boys are growing later and longer than the girls are. Okay, so we've talked a little bit about physical growth. Before we go on to formal operations, I want to say a couple of things about that sort of dramatic physical growth that we see in kids this age. It often results in some physical changes for them that sometimes can be a little difficult. For example, sometimes the physical growth occurs a little bit unevenly. So you see in kids often the hands and feet growing first, and changes in the proportion of the face that sometimes are kind of different looking. You see this in late school age and in middle school kids. You also see some pretty dramatic changes in the cardiovascular system. Syncopes are much more common in adolescence, probably because of the sort of massive adjustments of the cardiovascular system to all the growth that's going on during this period. So let's talk now about some other areas of development. Piaget, formal operational thinking. This is Piaget's fourth and final stage, which he said occurred between 11 and 15. Individuals move beyond concrete experiences and begin to think in more abstract and logical ways. He said it has 2 subphases, early and late. There's definitely a change in the quality of thought in children in this age group, and exactly when and how that happens has been the subject of a lot of research. Piaget said that these were the characteristics of formal operational thinking: hypothetical thinking, understanding transitivity, which means that things can go both ways, understanding abstract concepts, understanding multiple causation or possible multiple solutions to a problem, imagining things that they have not experienced, and anticipating long-term consequences of their actions. I'll say that formal operational thinking says that you should be able to do this, but adolescents don't always do this, and we'll talk in a minute about why that is. And remember, Piaget did most of his research and writing in the 50s, and there's a group in development called the Neo-Piagetians who look at Piaget's ideas in light of current research. And these are some of the conclusions that you see more recently about Piaget's ideas about formal operational thinking. The development of formal operational thinking is highly influenced by schooling and other environmental influences. And rather than develop in all cognitive areas, this characteristic is typically developed in modules in kind of a piecemeal fashion. So when kids are in school, they're often developing formal operational thinking about academic subjects, for example, before they might apply that to their personal life or to thinking about things in relationship to themselves. Some individuals apparently never acquire this level of thinking of formal operations, likely because of lack of exposure and to this sort of thinking. And other psychological characteristics can influence the development of formal operational thinking. We'll talk about David Elkind in just a minute and what he has to say about that. Along with formal operational thinking, we see the development of some critical thinking, and here are characteristics of critical thinking that you also see developing in this age group: open-mindedness, creativity, intellectual curiosity, being able to plan and strategize about things, intellectual carefulness, rethinking earlier conclusions, and questioning ideas. These come a little bit later in adolescence, but they are an important change that takes place in thinking in many adolescents, but not all. So let's talk a little bit about what David Elkind had to say about formal operational thinking. He agreed with Piaget's ideas about formal operational thinking, but he said that when adolescents first begin to develop these kinds of thinking capacities, that they tend to be fairly egocentric in the way they think about themselves and themselves in light of their new abilities. And as a result of this limits sometimes their abilities in terms of their formal operational thinking. And these were the characteristics of adolescent egocentrism that David Elkind described. Adolescents usually are very good at finding fault with authority figures, particularly their parents. They tend to be argumentative, probably because they're thinking that they have abilities to think and reason that may be better than others, or at least as good as others, so that they can come to their own conclusions. They seem to think of themselves as being somewhat invincible, in other words, not subject to the same rules as other people. Some adolescents have more of this than others. They tend to be terribly self-conscious, what Elkind calls an imaginary audience. They think people are always looking at them. Tend to be pretty self-absorbed, think of themselves in sort of magical fable ways, do a lot of daydreaming about some of those topics, tend to be fairly indecisive, and have what he calls apparent hypocrisy. They sometimes claim that they take on stances about things, but sometimes don't seem to be able to carry those ideas forward and apply them to themselves. So what does this mean for adolescents? It means that they're vulnerable in a number of ways in terms of their thinking, and that was the point of talking about David Elkind, because thinking of themselves as somewhat invincible and not being able to see always the logical conclusion of their actions means that they're in danger of making some poor decisions and engaging in some risk-taking behavior, which is one of the main risks that we see in adolescence, and we'll talk about some of those risks and look at some data on that in just a few minutes. So let's talk about Erikson, who's one of the foremost thinkers on social and emotional development. And for Erikson, identity was the key. He wrote more about identity than any other period in development because he thought identity was pivotal as the culmination of childhood and the beginning point for adult development. Identity is the coming together of all the different pieces of oneself into some sort of a whole image of who you are. Identity is never permanent. It's changing all the time. And certainly adolescent identity is built on things that have developed during childhood, but it comes together in a way during adolescence that is really very pivotal as children try to put together an image of themselves and who they are in a whole variety of areas. Now, James Marcia, if you remember, before we go on to Marcia, Erikson said that the sort of polar opposites of this period were identity diffusion and identity achievement. But James Marcia wrote a lot about identity after Erikson did, and he felt that there were other identity statuses among adolescents that one should be aware of. Identity diffusion meaning that the adolescent had made no commitments or experienced no crisis in relationship to identity. And identity achievement, obviously, that they had made a commitment to an identity. But he said there were two other states that one should be aware of. What's called identity foreclosure. This is an adolescent who hasn't really gone through a lot of personal angst over their identity, but has made a commitment to it, often simply adapting what their parents want them to be in terms of an identity. And Marcia points out that when adolescents have identity foreclosure, they often go back and redo this later when they're in college or when they're a little bit older. And an identity moratorium where people just postpone their commitment as ongoing work on the crisis of identity. And Marcia also says that a lot of American young people do this and often don't really complete their identity work until they're in college, so that they they are in somewhat of a state of identity moratorium during adolescence. So just something to think about as you talk to adolescents about their issues, about who they are and who they're becoming. Friendship's a very important part of adolescence, and Sullivan particularly put forward that there was an intimacy in friendship in adolescence that wasn't there in earlier childhood friendships oftentimes. Intimacy and similarity are the two common characteristics of friendships, particularly in adolescence. And he also pointed out in his writing that having older friends all the time in childhood and adolescence was linked with increased problems in children. So peer relations are very important among adolescents. Pressure to conform is strong, especially during the 8th and 9th grade. The early part of adolescence is usually more difficult and more troubling for both the adolescent and also for parents. This is often during middle school, when kids are really struggling with who their friends are going to be and really starting that whole identity business. And there's a lot of pressure to conform, and kids in early adolescence are more likely to succumb to that pressure to conform than they are a little bit later, when they have a better idea of who they are and who they want to be. Most high schools, there are 3 to 6 well-defined cliques, and oftentimes the group you belong to is related to your self-esteem. For adolescents, youth organizations can have an important influence on development. This would be things like athletic teams or religious groups or scouts, for example. Often important relationship to self-esteem and giving adolescents a group that they can really relate to. Career exploration is often an important part of adolescence. During adolescence, kids progress from the fantasies of childhood to more serious exploration of what they want to do with their lives. And often the kids are given the Strong Campbell inventory, if you're familiar with that, developed by Holland. Match up your career with your personality style and with your value system. I just want to mention that school transitions are often really stressful times for adolescents, and times when you sometimes see some difficulty at home or some acting out behavior, particularly changes from middle school to high school and then high school to college, or kids just expressing that they're feeling very stressed about things. Each of these has a progression to less structure, more diversity, increased pressure for achievement, less guidance, and more independence, and sometimes takes some adjustment for kids. So what are the health concerns that we have to deal with for adolescents? Well, nutrition is a big one. Adolescents are famous for not eating particularly well, and eating disorders, particularly among girls, are pretty common. Nutritional needs for girls at this period include increased amounts of iron and adequate amounts of calcium and vitamin D in their diet, because as the menses begin, girls need more iron in their diet, and the bone mass that you lay down in adolescence and young adulthood for females is largely what you're going to have for the rest of your life. So being sure that you lay down adequate bone mass is very important. Look for signs of eating disorders. Burns has a very nice chart on red flags in adolescence, and she has in there some of the red flags for eating disorders too, so that you're aware of those. And of course, this comes along with tracking growth during adolescence. Sexual maturation is a concern. You want to watch for growth in endocrine problems. Acne is often a big problem for kids during this period of time, and you want to have an armamentarium of ways to treat this and give appropriate referrals. Menstrual problems are sometimes a difficulty for girls. A lot of menstrual cramping and also premenstrual syndrome sometimes. Risk-taking behavior, because of the characteristics that we talked about before, and this involves a number of different areas. It involves sexual risk-taking behavior, which can result in sexually transmitted diseases and pregnancy, accidents and safety, and sometimes substance abuse as well. Now, if you aren't familiar with the Youth Risk Behavior Surveillance System, this is a survey of kids in high school that is done by the Centers for Disease Control every 2 years, and they collect volumes of data on youth risk behavior. It's really a very important surveillance system on what's going on with young people. It was last done well, the statistics we have are 2007. I haven't seen any 2009 statistics posted as yet, but it is done every 2 years. So I'm going to run through some slides here. It just gives you an idea of what some of the risk behaviors are in adolescence and what the current numbers are in relationship to this. So the first slide we'll look at is the percentage of high school students who had sexual intercourse for the first time before age 13. And it compares 1991-2007. So you see that number has gone down considerably, but hasn't changed a lot, say, in the past 5 to 10 years. And this is the percentage of high school students who currently sexually active. And again, we see a slight decrease in this, but not a lot of change in this since 1991. But about 35% of high school students are sexually active. So that's a good proportion of high school students. So this is a reminder that you always want to have that private conversation with them about their sexual activity. Now, I thought this was an interesting slide because we seem to be doing a better job over the past almost 20 years, 15 to 20 years, in teaching kids about AIDS or HIV infection in schools. Although the high point of this was 1997, we don't want to get too lax about this and let it drop, since this is probably accounting for some of the drop that we've seen in HIV infection. We often don't see that drop in HIV infection reflected in statistics in adolescence, but rather in young adulthood when HIV is picked up, probably as a result of exposure during adolescence. So here's a slide on chlamydia this isn't from the Youth Risk Behavior Survey. This is from another CDC project, but this shows you the positivity among women tested in family planning clinics by age group. And what I want to point out to you is that chlamydia and gonorrhea both have their highest incidence in adolescents. And then, of course, among young adults. As you see here, it goes right up the age groups right here in terms of chlamydia positivity among women. So you want to be sure that you are testing for this. Testing for it sometimes is difficult because doing that testing may not always be covered by insurance unless the patient has a symptom. But be alert to any symptom, including increased vaginal discharge, as a reason for code increased vaginal discharge. That will usually cover any testing that you do for chlamydia and gonorrhea. So here we see gonorrhea. The age groups are split out a little bit more clearly here, but again we see from 15 to 24 with the highest groups. Do note that both in the chlamydia slide and in this slide we've done a lot of improvement in the rates of infection of gonorrhea and chlamydia, which means we're doing better teaching about condom use is probably what that means. Probably as a result of HIV education as much as anything else. But still, the need to be testing people in this age group for chlamydia and gonorrhea. And here's the rates among males. So we see again that between 15 and 24 are the highest rates of gonorrhea among males here. If we look at syphilis, we see that one of the things we see here is that we've done a really good job of reducing the rate of syphilis infection, but we see that it's usually shows up in a slightly higher age group than we see in chlamydia and gonorrhea. But first graph on top here is the 20 to 24-year-olds and then the 25 to 29-year-olds. But again, a pretty dramatic reduction there. And this is among men. And we see kind of similar stats there. Okay, if we go on to other behaviors that we might be concerned about for health reasons, we're back to the Youth Risk Behavior Survey. We see percentage of high school students who reported lifetime cigarette use, that means did they ever smoke a cigarette? And you see that that number's dropped from 70% to 50%, which is really quite dramatic. So we're doing a better job in terms of talking to kids about not smoking. And here we see the numbers on students who reported current cigarette use, which means they are currently smoking or have so within the past month. And we see that that has dropped as well, having reached a high in 1997, and is dropping off quite significantly here to currently 20% at the last survey. Percentage of high school students who reported episodic heavy drinking activity now at 26%. Again, reduction in this over a period of about 15 years, which is good. Not as much as I think people would like to see. Percentage of high school students who reported current marijuana use has gone up and then down again, but about 20% of high school kids report current marijuana use. It's quite a few. Illegal injection drug use hasn't changed very much in this period of time. And inhalant use has really gone down. There have been a lot of public service announcements about use of inhalants, and I think that's made a difference here too, the potential dangers. So, a little bit of summary here. Adolescents are experiencing massive physical change and subsequent changes in their self-image, and early adolescence is often the most difficult time for both parents and children. Social-emotional issues revolve around identity and independence, and cognitive development centers on new abilities in thinking and processing information. So what are our concerns with our adolescent patients? We want to be monitoring physical growth and pubertal change, and be providing a sounding board for adolescents and for their parents. Be sure that you give adolescents privacy and support their decision making where possible. I want to add another thing here. Be sure that you ask parents if they have anything they want to talk to you about, because sometimes they do, and they need some privacy to talk to you as well about things that they're concerned about for their child. Support a positive self-image in kids. Say positive things about them. Try to help them see themselves in a positive light. Try to get an idea of how they feel about themselves in relationship to some of that identity stuff that's going on. Provide sound and thorough anticipatory guidance so that kids know what to expect, especially in terms of physical changes. Engage in some pretty straightforward talk about those physical changes, and it's always a good idea with parents and kids in the room to talk to them about discussing the physical changes of adolescence as kids get into the 10 and 11-year-old age range, and to ask them together how much they have talked about sexual issues, because you bring up the subject, and your bringing up the subject often makes it okay for parents then to broach that subject with their kids, especially if you tell them that it's time to start talking about that and open that discussion with parents and with children. Watch for developmental red flags. See Burns. She has a really nice table in there with developmental red flags for adolescents that you should watch for. And of course, when you see those, be sure that you make appropriate referrals for help.